Good evening, everyone. My name is Maria Yeseta. I'm one of the physical therapists here at CASA. I've been here for a little over 12 years, and I have my board certification in neurologic practice for CT. Tonight, we're going to be doing a talk. We're going to start with Dr. Popalzai, who's our neurologist, who will be going over stroke risk factors, what does stroke look like, what are some of the presentations that you'll see, and then I'll jump in the second half to talk about what rehab post-stroke looks like and what we have here at CASA to offer.
Thanks, Marie. She asked me to give this talk. My name is Adeel Popalzai. I'm a neurologist. I serve the community. I've been at Casa Clina for 12 years, almost. And then, yeah, we'll be talking obviously about stroke. If you're not aware, May is Stroke Awareness Month. So we really try to put a focus on it during this month to kind of educate the community and the staff about stroke and stroke awareness. Like Marie said, yes, I'm Dr. Popalzai. I'm the stroke medical director at Pomona Valley Hospital, which is a comprehensive stroke center. And I also work here at Casa Clina, which is obviously a rehab center. So obviously, both hospitals together go hand in hand because stroke is both an acute problem, but also post-acute and rehab. So we work pretty well together. The goals of my talk specifically are specifically to talk about what is stroke, how can we recognize what stroke is and the risk factors that can predispose patients to stroke, the simple signs of stroke that you can sometimes identify, and then treatment options. And then Marie's going to go more into the rehab portion of things in terms of post-stroke recovery. So first question, what is a stroke? Well, actually, I'm going to stop here. Show of hands, and you don't have to raise your hand, but I'm just curious, who in here has been affected by either themselves or like a loved one having a stroke or friend? So quite a few of us. Okay. So stroke is now the fifth leading cause of death in the US, actually. When I was training, it used to be the third leading cause of death. So we've made actually some progress, but it is still the number one cause of disability in the United States. So obviously we take it very seriously. What is a stroke? Simply, stroke is basically a blockage of blood flow going to a certain portion of the brain. It is sometimes referred to as a brain attack, just like we have heart attacks, it affects the brain. Similar to what a heart attack does, impairment of blood flow to the heart, this is an impairment of blood flow to the brain. So there's two types of stroke. Number one being ischemic, which is a blockage of blood flow due to an embolus or a thrombosis. It's like a clot that blocks off a supply of the blood flow to a certain portion of the brain. And then there's hemorrhagic stroke, which is a rupture of a vessel in the brain causing bleeding. And then both types of stroke can have similar presentations, similar risks, similar presentations and symptoms, but treated very differently, obviously. The bulk of stroke is actually ischemic. 87% of all strokes are ischemic, and 13% are hemorrhagic. You may have also heard of a TIA, or people like to refer to this as a mini stroke. I don't like that mini stroke definition because that implies basically that you had a stroke. But by definition, TIA is a temporary event. It's a transient ischemic attack. So it's really more of a warning for a stroke than it is a mini stroke. So I don't like that mini stroke definition. But basically what happens is you get stroke-like symptoms that are temporary and that spontaneously resolve. Generally, they resolve within 24 hours, but classically, TIAs last no more than 1 to 2 hours normally. They lead to the same types of symptoms that you would have with a stroke, whether it be ischemic or hemorrhagic. But the good thing here is that they are temporary and transient, and then they self-resolve and you go back to normal. And again, the reason why I call it a warning for a stroke is before patients actually have strokes, 12% of people actually have TIA events right before it. So they get a warning that something may happen that may predispose them to an actual stroke event. And so the risk of stroke peaks 90 days following a TIA, but the more severe your symptoms are during even that TIA event, the higher the risk of you actually potentially having a stroke. So it's really important to kind of be aware of even a TIA event. So again, whether it's stroke, be it ischemic, hemorrhagic, or even a TIA, and it spontaneously resolves, we still encourage everyone to get medical attention as soon as possible. Come to the hospital, call 911, because they will transport you to the closest stroke center where we can potentially do something to help. So a big portion of why stroke is so important and why we pay so much attention to it is because the brain. And I'm a neurologist, so I'm a little biased, but I think the brain is probably the most important organ. It basically controls most things, whether they be voluntary or involuntary. It controls our movement, the way we feel things, the way we perceive the environment, the way we talk, our speech, our swallow function. It can even control subtle things like heart rate, breathing. So a lot of things, most things are controlled by the brain. Depending on where the brain is affected by this blockage of blood flow, you will have symptoms that will maybe cause weakness on one side, or have numbness or tingling on one side, or having difficulty speaking. So it's important to kind of understand those symptoms so that we can do something about it right away. So some stroke facts. Stroke, yes, can affect anyone at any age. This is very, very true. Normally we think about this as being more of a diagnosis or problem for elderly populations, but we're seeing more and more frequently that younger patients are actually having strokes. And believe it or not, even pediatric patients can have strokes. So it can happen to anyone at any age. Obviously, the greater risk factors one person has, the greater the risk of stroke. And yes, technically, as we age, basically for every decade above the age of 55, our stroke risk doubles. So age is one of those non-modifiable stroke risk factors. We can't reverse our age, but as we age, our stroke risk increases. So the other thing is that actually Hispanic and Black populations have a higher risk of stroke and higher death rates actually too. So there are certain factors that are modifiable, which we'll talk about, but other non-modifiable stroke risk factors like our genetics, our race, our age, those are things we can change, but that can also increase our risk of stroke. So we're going to talk about a few things, including risk factors and some of the symptoms to look out for, but the basic thing from this talk is I want everyone to come out of this being stroke smart. So we want to learn how to prevent stroke, how to recognize stroke, and to understand that both stroke is preventable and treatable, okay? And a big portion of this is the rehabilitation, because a lot of us who have had stroke or loved ones who have had stroke, you've seen what happens post-stroke. And rehab is a huge part of our recovery and treatment. So the most important thing really is to understand what our risk factors are. Stroke is becoming a little bit more individualized. We obviously approach every patient with extreme attention, but we are looking specifically at what everyone's stroke risk factors are, because if we can identify those stroke risk factors and treat those stroke risk factors, then we could potentially prevent stroke. So some of the most important causes to be aware of, or the risk factors, are obviously high blood pressure. This is the number one most modifiable risk factor for stroke. If you have high blood pressure over time, if it's untreated or not treated well, it causes damage to our blood vessels everywhere, but we're thinking about the brain, and it definitely increases your risk of stroke. So that's the number one most modifiable stroke risk factor. Obviously, high cholesterol also is a big part of it, because high cholesterol causes deposits of atherosclerosis and calcium along our vessel walls, which can make them a little bit more narrow and prone to stroke. Smoking is a big risk factor for stroke. So if you smoke, or if you do that, don't do it. Obesity, big problem. I mean, I think in this country, there's a big problem with obesity and just a sedentary lifestyle. If we can target that even, that can help prevent stroke. And then, of course, there's diabetes. Diabetes falls in line with the other vascular risk factors of high blood pressure. And all these risk factors also are risk factors for heart attack as well. So we want you to really hone in on these. If you or your loved one have any of these risk factors, it's really important to follow up with your primary care physician regularly, to monitor it, keep it controlled, because 80% of stroke can be preventable if we identify and treat these risk factors. There are additional risk factors, of course, as well, but the big one being AFib or atrial fibrillation. Not sure if you guys have heard of this. It's an irregular heartbeat, and that irregular heartbeat causes us to form clots in our heart. These clots can travel up to the brain and cause very serious stroke events. So it's really important to know your heart health and how your heart is functioning. And if you do have AFib or atrial fibrillation, it's important to treat it, to control the rate, and you may even need a stronger blood thinner if you have it. Now we kind of have these watches that are nice. They can actually catch AFib. So, now we have all these devices that are kind of detecting these things as well. Carotid artery disease. These are the arteries that supply blood flow to the brain and the neck. These are major arteries that if they get narrow or if they're developing atherosclerotic plaques or stenosis, can definitely increase your risk of stroke. So if you have carotid artery disease, that would be another definite modifiable stroke risk factor. Some additional factors, of course, heart health overall is important because the heart is important because you can have clots that travel from the heart irrespective of if you have AFib or not. You can form clots. You can actually have a small hole in your heart called a PFO, and clots can travel through that hole and travel up to the brain. So again, it's important to know your heart health. Some people can have clotting disorders. They're more prone to forming clots. Cancer itself is a risk factor for forming clots. So technically, even if you have cancer, you're at higher risk of stroke. Even pregnancy is a risk factor for stroke because you're actually at more risk of forming clots during pregnancy if you didn't know. It doesn't happen often, obviously, but it is a reason to clot a little bit more easily. We talked about smoking, but excessive alcohol use is definitely one of those things that we want to modify, adjust, and limit. Any liver dysfunction can cause problems with our clotting, and we can bleed a little bit more easily if there's liver dysfunction or hepatitis. And then we talked about some of these non-modifiable stroke risk factors like age, ethnicity, and race. We can't change those things, but if we know that we're at risk, then we should be kind of more aware of what our other risk factors are to try to prevent stroke. And then physical inactivity goes along with that whole sedentary lifestyle and potential obesity. So we encourage people to be as active as possible. So I kind of hit this a little bit, but if you can identify your risk factors for stroke and talk to your primary care physician, you can really prevent stroke. Like I said, 80% of strokes are preventable if we can identify our risk factors and treat them appropriately and keep those controlled. So it's really important to kind of follow up with your primary care physician and your team of doctors to kind of see where you're at. We're going to keep hitting this. Take control of your health. Know what your risk factors are. If you smoke, stop. If you have diabetes, and if you've heard of an A1C, which is the value of how bad your diabetes is doing the past 3 months, know it. Get that down, control your blood sugars. Consider dietary changes. Typically, a Mediterranean diet is more beneficial and better at preventing stroke, but nowadays we have it so easy with fast food and things like that. It's really important to kind of eat healthy and watch what we eat. And if you do eat kind of those things, kind of eat in moderation and just be a little bit better about overall diet. And then, of course, taking prescribed medication. I can't tell you how many times people come to the hospital saying they have high blood pressure, but they're not taking medicine because they're walking, and they're being active. They don't know that their blood pressure is actually elevated. So if it is persistently elevated, it's one of those things that we may be unaware of. It's really important to take your prescribed medication to control these things because, again, over time, high blood pressure, diabetes does cause damage to our blood vessels in and around the brain and can increase your risk of stroke. So again, know your risk, lower your risk. It's important to exercise. The American Heart, American Stroke Association encourages as much exercise as you can tolerate. Some people can do more, some people can do less. They say about 150 minutes of mild to moderate exercise is what's recommended. If you could do more, great, but obviously listen to your body, don't overdo it. Eating healthy, controlling cholesterol, managing our diabetes, our blood pressure, stopping the smoking. Smoking is one of the worst things. We sometimes think about smoking associated with lung cancer, but smoking does terrible things to your blood vessels. So if you smoke, try to stop, treat the blood pressure, avoid alcohol, limit alcohol consumption. These can all make a difference. So we know that stroke is preventable if we address these risk factors, but stroke is also treatable, okay? In the past 5 to 7 years, stroke management has really changed dramatically. We are recognizing symptoms and we're able to treat them. But again, this is a time issue. Time really is brain. So if you, your loved one, or anyone is having stroke symptoms, the clock starts immediately because you lose about 2 million neurons per minute when you're having a stroke. And you want to recognize symptoms, get to the closest stroke center you can because we can give life-saving treatment within a certain time period. Specifically, there are blood thinning medication, clot busting medications if you're having an ischemic stroke. And if you recognize that within 4.5 hours, of symptom onset, we can give you this medication, and it can make a tremendous difference. And now we're doing procedures where we will actually go in and retrieve clots from the brain. And people will come in not moving their whole right side, and then they come out walking. So these are really important things to know, and really important to understand that, yes, stroke can be treated, and we want to treat things as soon as possible. And then your chances of surviving and having minimal disability is higher if you get treated. Again, stroke, we think about the brain, what it can do, but we're really trying to minimize disability. You know, a stroke can affect us with weakness, speech difficulty. These are life-altering things. So if you can try to, number one, prevent stroke, or if you're having an event or your loved one is having an event, it can be treated, you can really minimize that disability. What does a stroke look like? So we use the acronym BFAST to educate the community to kind of be aware of what to look for. The B stands for balance. You can have difficulty walking, you can have dizziness, and your coordination can be affected. So that's the B. The E is eyes. You can have a loss of vision, blurred vision. That matters. And these are all sudden onset symptoms. So typically stroke is something that happens suddenly. It's not generally something that happens gradually over a couple days. You will have sudden onset of these symptoms and some kind of change. Face, that just shows you that you can have a facial droop, and that may also cause slurred speech, difficulty swallowing. So if you recognize someone developing a facial droop, it's important to call 911. The A is for arm, but really we want to focus on arm and leg. If there's any weakness of the arm, weakness of the leg, specifically, typically on one side of the body, beware, call 911. Speech, obviously, if someone's having difficulty getting their words out, or if they're slurring, that's a big sign of a stroke. And then the T is for time. We want to really emphasize time. Call 911 as soon as you can. Get to a stroke center so we can potentially treat it. Like I said, every one of these bullet points is sudden, sudden, sudden. So sudden numbness or weakness, usually on one side, face, arm, leg, or it could just be arm, it could just be leg. Sudden onset of confusion, trouble talking, trouble even understanding. Sometimes people think, oh, he's just like confused or something's wrong, but it could actually be a problem with their speech. Trouble seeing out of one or both eyes, blurred vision, loss of vision, trouble walking, dizziness, coordination issues, and then even a sudden severe headache of no known cause. And usually those headaches are pretty bad. That can be a sign of a stroke. So again, signs of a stroke are sudden onset of all these potential symptoms. And what does treatment look like? We kind of talked about that, but these life-saving treatments are the clot-busting medications that we use now. And again, these can be used within 4.5 hours of the onset of symptoms. So we want to identify symptoms, get them to a stroke center so we can treat with this medication. And then, of course, there's now the clot retrieval that we're doing. For large clots that lodge into a big, large artery of the brain, generally the symptoms are much more severe. And so we can actually go in and try to retrieve this clot if we can identify it. Again, that means getting to a stroke center as soon as possible. And we have one in our backyard here at Pomona Valley Hospital. It's a comprehensive stroke center where we can manage all these things. And then, of course, testing and treatment. When patients come in with stroke symptoms, they go through a battery of tests to identify other stroke risk factors. When someone has a stroke, unfortunately, that's not just it. That means, yes, you're at risk of stroke in the future, but if we can, again, treat and identify those risk factors, we can prevent stroke. So we want to know if there's any heart issues, any clotting issues. Is the blood pressure uncontrolled? Is their diabetes uncontrolled? Are they smoking? Can we identify these things? Can we treat them and then maybe prevent stroke in the future? And then a big treatment moving forward after a stroke is really rehab. So I know Marie's going to hit on that, but rehab, I can't really underscore how important rehab is into getting better, because the brain really does have a way of relearning some of these connections that can be lost from a stroke, and rehab is a key to that. So stroke recovery really is technically lifelong, and rehab is a big part of that. So after a stroke, the American Heart American Stroke Association says 10% of stroke survivors recover almost completely. That's a low percentage. Yeah, not the best. But again, those patients that are treated with either the clot-busting medication or clot retrieval actually do much better. 40% of patients who experience a stroke will have moderate to severe impairments that require special care. This can be life-changing, profound disability. This can affect many things. It can affect their life, but their family members' lives too, their income, a lot of things. It can affect their mental health down the line too. So again, important to recognize. And then stroke survivors may have challenges in multiple things. Obviously, physical abilities, their activities of daily living, communicating, the ability to understand, write. And then a big thing is emotions and behavior, because a large portion of stroke patients will have post-stroke depression. And that's a real problem because you're already dealing with the physical limitations, but then also you have to deal with the behavioral issues too sometimes. So again, please try to recognize what risk factors you or your loved ones may have and try to address them, and this actually can be prevented. The impact of stroke. Stroke reduces mobility in more than half of stroke survivors above the age of 65. So if you think about that, obviously a larger portion of patients that have stroke are older, and the older you are, the higher the risk of higher disability. Post-stroke effects. Changes to the brain are depending on what part of the brain is affected. So this slide is nice because it kind of highlights different areas of the brain. The frontal lobe, the red, the yellow, the parietal lobe, blue occipital lobe, purple is the temporal lobe. There's two sides, two hemispheres to the brain. And depending on where that blood flow is impacted, whether it be by a bleed or an ischemic stroke, it can affect someone's personality. It can affect their right side, which could be their dominant side. It can affect their speech. If you get a stroke which can affect the brainstem, that's down here, that can actually affect breathing, heart rate. So all these things depend on where the stroke was affected. The occipital lobe, sometimes you can just have a visual issue, which is an impairment of vision on one side, and that is a sign of a stroke that affected the occipital lobe. So it really depends on the location of where the stroke affected you and how that will impact someone's disability. This kind of hits on the two hemispheres. So in general, the left hemisphere controls the right side of the body. So the left hemisphere controls the right arm, right leg, right side of the face. Left side controls the right side. So the other thing is that 90% of us have a dominant left hemisphere, which means that our speech center is in the left hemisphere. So if you have a stroke that potentially affects the left hemisphere, most of us are right-handed, and then our speech is also affected. So these are big, very impactful strokes. And then the right hemisphere can affect other factors. So again, it's important to kind of be aware that strokes can affect people differently. No two strokes are the same, and it really depends on what part of the brain was affected. Post-stroke effects, we talked about this, but again, everyone is different. Everyone's affected by stroke differently. Obviously, we think about the more impactful things like movement, walking, when one side of the body is affected. Memory can be affected. Our thought process, the way we respond to outside or external stimuli can be affected. We may not be able to even understand the way someone talks to us and be able to get the words out correctly, depending on the location where the stroke was. Our vision can be affected. Stroke can sometimes even cause more pain with certain areas of the stroke, specifically in an area called the thalamus. You can get something called thalamic pain syndrome. It can actually be a very painful sensory issue. Bladder control can be affected. There is a really significant post-stroke fatigue that happens to anyone in stroke. Sleeping can be affected, and of course then mood as well, with depression and anxiety and things like that can develop. So again, all these things are depending on where that stroke affected that person. But the beauty of this, technically, if you want to say the beauty of it, is that you could get better, okay? There is improvement after stroke, and really the stroke recovery is lifelong, but in the first couple of weeks to months, it's really important to hone in on therapy to try to help improve those connections that are kind of missed because of where the stroke affected you. So rehab is going to be huge and important. And then Marie's going to talk more about that, but that's my part. So if anyone has any questions, I can answer. Yeah.
Does heredity play any part in the probability of you having a stroke?
Definitely. If you, if your parents or if your family members have a history of stroke, their stroke probably happened because they have something like high blood pressure, diabetes, or heart disease. And then you are technically more at risk of that because you carry the same genes. So yes, absolutely. That's a great question. So we're seeing a larger portion of younger patients have stroke, and trauma can induce stroke events because unfortunately I've seen even in car accidents or some certain things that you can actually have an injury, a whiplash injury, and you can actually cause a tear on the inside of your blood vessel. That can cause a clot to form that travels up. So it's called a dissection. But yeah, trauma can absolutely cause a stroke, unfortunately, yeah. I saw you first. Oh, yes, you and yes.
Earlier you mentioned about
Yeah.
how accurate are those?
I can only say about Apple watches because I know the newer Apple generation of watches do detect AFib. It is fairly reliable, but not 100%. But there's more data that shows that actually is pretty good. But if you get that alert, you got to talk to your doctor, you know? Yeah.
Does it only show AFib?
As far as I know, AFib, yes. That can definitely lead to a stroke. AFib is one of the biggest risk factors for actually a severe stroke. So if you find your watch saying it's going in and out of AFib, you gotta get that checked out. You had a question.
Yeah, does a stroke show up on an MRI?
So by definition, remember, TI is resolution of symptoms. Your symptoms are temporary, so that MRI won't show a stroke. If you have an MRI that shows a stroke, then by definition, it's not a TIA because there is evidence of a stroke on that MRI. So a TIA will generally have an MRI that's normal, and if you have a stroke, you'll see that area on the MRI. It's not bad news, though. We want to identify risk factors, and remember, stroke, if you learn anything from this, it's preventable and treatable, okay? Great. Thank you, guys.
I'm going to take over for the next part and talk more specifically about the rehab process. So we've learned what stroke can look like, and we know that that could be different for everybody, but we do have those hallmark signs and symptoms that we can look for. So we want to make sure we know what our risks are, make sure those are managed and treated. If we do identify anybody that shows a sign of a stroke, number one is get help ASAP. And that really does start by calling 911. Dr. Popalzai mentioned that they can get you to a stroke center. Triage for stroke starts at the level of a 911 call. There's things that they can do in the field. They can make sure you go to the right facility. We're lucky enough to live and be in an area where we have access to a lot of resources. If you're in other parts of the country or other parts of the world, that access may be very limited. And so time becomes even more critical. They may not have that clot busting drug at every hospital. They may only have it at one site and they might have to get it in. They might not have neurologists at every site. They might have to do telehealth to get somebody on board. So really, if you see anybody, even if you're not sure, call 911. That's the first line. They'll help triage whether or not, does it really look like a stroke? Do we need to go to a stroke center? And that timeliness of getting to imaging, getting to the medication is really critical. But what we're going to switch to now is talking about recovery. So if we have somebody that's had a stroke, what does recovery look like? So rehab post-stroke is the goal. We want recover as much function as possible, get back to their normal as much as we can. It's definitely going to involve support system for that individual, family, friends, caregivers, new strangers that you didn't meet until after your stroke happens that you form a bond with. But we can see two people with the very similar type of stroke and similar presentation that recover very differently, exclusively based on their support system as well. Rehab typically starts within the hospital level of care, and then they figure out what's the next step from there. And the best option is really individualized, but oftentimes depends on the severity of a stroke. So stroke recovery and rehab can start after the acute hospitalization in a rehab facility like we have here at CASA. It might be at a subacute care facility where maybe there is some therapy, but intensity is a little bit different. It could be home-based. It could be outpatient therapy where you go to the clinic to receive services. Or it may be that somebody requires kind of long-term care in a facility setting. So that's really going to depend on the individual, their needs, their support, and how severe their symptoms are. And it doesn't mean that you can only get treatment in one place. It may mean that you start in acute rehab and then you go to outpatient and then you join a community program after. So it's not meaning that you're locked into one. You just can't typically get them in more than one place at the same time. So here at CASA, we have a continuum of care. and it has a lot of different opportunities where we might encounter somebody who's had a stroke. Our programs are guided by our physicians, but is really interdisciplinary, meaning there are multiple different providers that are at the table to work with individuals. And each person that comes through the door, we're tailoring that program to that person every single time. So you'll hear we have these general testing batches that we need to do for somebody who's had a stroke to look at their risk factors. But that may mean for somebody, oh, we know that you have this condition. Now we've got to dive and see if your meds are really effective, where that may not be the case for somebody else that doesn't have that risk factor. So it really is tailored to that individual. So here at CASA, we have a whole slew of different things that you may encounter, but we have a medical surgical unit. We have our inpatient rehab, where it's a hospital-based rehabilitation program. We have our outpatient services. We also have specialty clinics, so things like a wheelchair seating clinic, adaptive technology. We have specialty services for those. We have our outdoor adventures program, which you'll get to hear a little bit more and see a few things later. We have community programs like this one and others, and we also have a research institute. So both providing research opportunities that are helping move us forward here on campus in collaboration with other institutions, and then also bringing in people to launch new research opportunities. So two of the main areas that somebody might encounter stroke rehab while they're working on their recovery would be the inpatient or the hospital-based program or our outpatient services. So hospital-based, they're going to go to that acute hospital first, right? You call 911, they take you to some place with an ER that has neurologic services there. They're looking at those clot-busting medications if appropriate, that clot retrieval procedure if needed. Once they're stable, then they figure out where do they go next. It might be deemed the most appropriate that they come to an inpatient hospital-based facility. So oftentimes that's where I work the most, is an inpatient, so that's where I typically will see people. Or they may go straight to outpatient. They may come to the hospital first and then go to outpatient after. But lots of different providers available in both areas. We're looking at physician, specifically like a rehab physician and or neurologist that's managing the care. We've got therapies, so physical, occupational, and speech therapy. We also have recreation therapy. There might be some specialty services like a neurooptometrist, an audiologist, psychology, neuropsychology, really looking at the breadth of what each individual would need based on their presentation. So how does recovery work and what does that look like? So we're really going to look at what does an individual need, what are their goals, and what are the best treatment options for that person. This might mean that we're working on caregiving skills for somebody that's a new mom that had a stroke during the process of birth. It might mean that we're working on how do you play with your grandkid and go to their soccer games if that's the role that you're in. It really depends on that person and what they want to get back to. Are we getting back to running? Are we getting back to driving? So whatever that person needs, we're going to meet them where they're at and work towards those goals. Our physicians are going to lead, and our therapy programs are going to be in conjunction with their medical management for the patient. We also make any of those referrals, like I mentioned, some of those team members on board. If we need psychology on board, if we need neurooptometry, we'll make those referrals. And so in addition to working towards those goals, we're also making sure we're working on preventing the possibility of another stroke, managing those risk factors like Dr. Popalzai was mentioning. So how do we make changes in the brain? The term that you'll hear, sometimes you hear it now like on the news or in different stories, but neuroplasticity. This is the ability of our nervous system to make changes in response to different stimulation. It's going to do that by reorganizing the structure of the actual nervous system or reorganizing the function of that nervous system and its connections. So this is how we make changes to our brain. That being said, it can be a positive change or it can also be a negative change. And this is happening all the time, all around us, but when we talk about stroke recovery, this is how it's working. So what does that look like in the brain? Normally, we have signals going from one cell to another within the brain, forming a connection to tell our body what to do. So I say I want to lift my arm up. I've got a whole pathway of signaling that's happened from one neuron to the next that results in me lifting up my arm. When a stroke event occurs, whether that's a clot or a bleed, we get death of brain cells. Okay? So it happens in the bleeding, we get more pressure, we get lack of oxygen to the cells. Same thing happens in the clot. So we get destruction of areas of the brain. How much, how big of an area really depends on the location, the amount of bleed or clot, the time to treatment. That's why when we talk about time is brain, that's why. So now we have a disruption in the signaling that we would normally see. We don't have the same pathways happening. With neuroplasticity, the goal is to try and start to form new connections where we're forging new pathways. Because if I had a stroke, it doesn't mean that instantly my muscle is no longer healthy, but the connection from my brain telling my muscles what to do has been affected. So now we've got to lay down new pathways to get our body to do what we need it to do. And sometimes we may have overlap where a few different areas of the brain work together to make a function happen. So sometimes we can strengthen an area that was kind of doing a dual role and take over for the area that was affected. So some of the terms that you'll hear or how neuroplasticity works are we have to use it or we're going to lose it. So this is where I talk about neuroplasticity can also be a bad thing. If we don't practice something for a period of time, we might start to lose that function, right? If we think about, I haven't ridden a bike in 7 years, it's probably not going to be the first thing I do when I hop on that bike is not fall over, right? Because I haven't used that function in a long time. Doesn't mean I can't access it, but if I don't use it, I'm going to start to lose some of that function. Also, if I use a particular function or I do a particular movement over and over again, I can also make it better. We have this line down here where intensity matters. So if you picture, you go to the gym, you're picking up a 5-pound weight. You might start off getting stronger, and then after a while, you're going to stay kind of in a holding pattern, right? That's because our bodies need a challenge. So once our bodies meet a challenge, we have to keep going. If we don't make it hard enough, our brain's not going to learn anything new. So when we talk about neuroplasticity, we have to do a lot of repetition of very specific activities, and we have to do them at an intense way. It also means that we need things that are meaningful to the person. So if I have them do an activity that they have no interest in, they never do it in their daily life, it doesn't mean anything to them. Their brain doesn't have that buy-in. It's not going to make the same improvement. So we want meaningful activities, we want purposeful activities, we want high repetitions of it. We need hard things for our brains to get better. So this can be applied kind of across the board for different things. It can be applied to motor recovery. So if I have weakness in my arm or my leg and I'm doing exercises specific to regain those motions. It can be to swallow function, to speaking functions. And we want to do this in conjunction with the medical team so that we're optimizing that opportunity for improvement, managing any secondary effects. So you can imagine we've all had those nights where we don't sleep well, right? Now picture you haven't slept well in 8 days and you had a stroke and things aren't moving like you want to. We need to make sure that sleep is managed so that then we can be effective with the training that we're trying to do. Otherwise, you wake up every morning sleepy, not wanting to get up and go to the gym, not wanting to do your exercise program because you don't have energy to do it. So when we talk about managing in the team model, it's all of those pieces that go together. If I have pain, we need to make sure that pain is managed and under control. If now my blood pressure has been super high and we're trying to bring that down to a manageable level, I may need some time to adjust what my body feels like with the normal lower blood pressure. All of those things come together in a head when we're working with stroke recovery. So some of the areas that you'll see us tackle with stroke rehab is the big one that you can kind of picture the easiest is mobility recovery. So if I can't move my limbs in the way that I want to, or I don't have enough strength to do so, we're going to be working on that area. We're going to be working on balance. We talk about daily activities. That's everything from what you do the first moment you wake up to what you do when you go to sleep at night. So that's getting yourself dressed, bathing, grooming, being able to take care of yourself, go to the bathroom. It's all the hobbies that you like to do, the work that you do, whether that be at home, out of the home, caring for younger children, caring for older individuals, whatever it is that you do to occupy your time throughout the day, those are things that we're going to target in therapy. So these are just some examples of some interventions that we use specific to target mobility. And what we're going to be doing later on and a little bit after the talk is getting a chance to see some of those technologies here in person. There's a few things that I can't bring with me. For example, we have an overhead track harness system. We have it in 2 locations on campus, but it's a body weight support system. So if you can picture in your mind a harness that you would hook on if you were going to go bungee jumping, kind of looks like that, but it attaches to a track on our ceiling, and we can support somebody's weight, 10, 20, 30 pounds, whatever we need, and allow them the freedom of movement while giving them a little bit more security if they were to have a fall, but also to support them a little bit more so they can participate in training. So we can do everything in there from return to sport. I had somebody working on getting back to surfing. They were getting from flat on their belly to standing in one full motion, walking, balance, all different kinds of things. We have electrical stimulation, which is a way to stimulate the muscles in the periphery. So we can put it on their arm, we can put it on their face, their leg. We can even use it to help swallow function. And we use electricity to help those muscles contract so that we can practice all those movements that we need to improve the functions. There's some of those devices, like this one is a wearable cuff that somebody can actually wear while walking and doing those activities over and over again. We have different systems for balance, we have robotic devices, but they all come back to the same principles of that neuroplasticity. How are we going to get the brain to change? We've got to do hard work, we've got to do a lot of it, and we've got to do things that make sense and are meaningful to the person. So that's really what all of these tools are, and the things that you'll see later are about. Our speech therapists deal with our communication skills, so how we're talking, how we're receiving information, our thinking skills, so being able to remember things, but also how do we organize things? You know, are you using a calendar? Are you able to remember a list in your mind when you go to the grocery store? Are there things that have been impacted after a stroke? They can work on that. And a big one that happens is swallow function. So they can work on exercises and techniques to manage safe swallowing, which includes for some people modifying their diet, be that temporarily or long term, so that they don't aspirate and have other issues with that. We can work on vision, which also kind of tailors into a lot of people wanting to return to driving, right? That's a big source of independence for many people. Here at CASA, we have a simulator in our outpatient department, which is like a multi-screen device. You actually practice being on the road, things jump out at you, you have to make correct decisions, timely decisions. And then we also have an on-the-road training program that's separate. So they do a whole driving eval on the road. And some people need adaptations to their vehicles, so we can even talk about different things that might need to be adapted for somebody to be able to do that task. We've got different things that we can do for the environment and how somebody accesses the environment. So things like specialty equipment for maybe somebody who's going to be a part or full-time wheelchair user. We have different things that we can do to make that efficient and effective for them in their daily life. And we also have different types of specialty equipment that allow us to interact with our environment. Does anybody have like a speaker at home where they can talk to somebody on the internet, like an Echo Dot or an Amazon device or a Google device? You can ask them the weather, you can make your grocery list. We can also use devices similar to that to control our environment, right? Alexa or whatever you call your device, can you turn the lights off? That may be really important for somebody that doesn't have full control of their limbs. We can do a ton of things where you can actually tap that right into their wheelchair. They can control their phone, they control their environment, all through different ways to access technology. There's also ways to do that to help with speech production. So somebody may be using a specialty device to allow them to communicate with other people. But we have all different kinds of ways to tackle that and really individualize it to the person. And then one of my favorites is how are we getting back to all those things that make life fun, right? We have a huge outdoor adventure program, and they focus on creating opportunities that are challenging and exciting, that really focus on people's abilities. How can I get back to golf? You know, we're working through this process of recovery. We've talked about maybe we get back to 100% recovery, maybe not, but there are still tons of things that you can do, and you can go back to doing your hobbies. And so there's a lot of ways that we can engage in that. And so it's about success. It's about getting back to things that you love. And it's both not only a physical participation, but it's an emotional experience, right? I haven't been able to golf in 5 years, and now I'm able to do that. It might look a little different than what I was doing, the way I was playing golf before, but I'm able to do it. And then we also have our research institute. So for somebody recovering from a stroke, they may encounter our research institute because we're sending out flyers about some new studies that we're doing. It may also be that they're receiving a treatment because we've done research on it in the past and know that it's effective, or we know that something maybe isn't so effective, so we're not going to do that anymore. Things like we talked just briefly about sleep apnea being a risk factor for stroke. That's come to light a lot more in the more recent years, where it's gotten a lot more publicity, a lot more press about that being a strong risk factor for stroke. So we have studies that are ongoing on campus about how can we intervene, how are we screening for it, how many people are not knowing that they have a history of obstructive sleep apnea, and how can we impact that while they're here, and then follow up with care later. So we're looking at basic research, translational research, and clinical to see what we can do to transform our advances and really inform the practice that we're providing to our patients. So many of our patients currently that are on our rehab unit right now are all participating in research studies, and some of the devices we have in the back are actively being used on the unit by patients that are participating in studies.